Thank you all for staying for the last presentation. I am Dr. Dana Granberg-Nill, currently COO and Medical Director at AFLDS. I was in practice for 20 years plus and then left my private practice and joined with Dr. Gold, who I have the pleasure of working with now, creating a better way to deliver healthcare. It's been my honor to get to know the kind of physicians that you've seen speak here today, and even a couple of attorneys. You know, if they're on the freedom side, I actually have grown to love them too, and scientists. So I hope that you will see through my talk just a little bit of a contrast of the kind of care you could expect from a doctor that was on this stage compared to the kind of care that the current MIC, Medical Industrial Complex, is delivering. So for those clinicians that are getting CME, and thank you, Dr. Avery Jackson, for providing CME, these will be my objectives today, and we're gonna start with number 1, and I will identify the objectives as we go through. This is a pretty busy slide, but I'm not going to spend a lot of time on it. I put it up because I think that the burdens and the barriers in our current healthcare system are intuitive, and I think, frankly, they're quite obvious. But I did want you to look at the bottom to see where I got some of the sources of information, because I'm gonna summarize this whole slide here in one word, which I think is the biggest barrier these days to healthcare. Kaiser Family Foundation, JAMA Network, Physicians Foundation, Medscape, Commonwealth Fund, Pew Research. These are many of the sources. And if we did these things well that are listed as burdens, if we did them with excellence, we would increase trust in the system. But I would submit to you all that we are not doing these with excellence. And so that right there, trust, is what I believe right now is the biggest barrier to healthcare in the US. The first highlighted title up there, Trust in Medicine, the Health System, and Public Health. It was published in 2022, and it reviewed 40 years of polling. And in those 40 years, you can see that trust in medical professionals dropped from about 73% in 1966 to about 34% in some measures, and we'll talk about some of those measures on the next slide, by 2012. And if you think about the number 2012, that would be a re-election of a certain someone. I have no idea if that would have any effect on this, but I'm just trying to put into perspective, this ended before COVID. So if you look at the second study there, Trust in Physicians and Hospitals During the COVID-19 Pandemic, published in 2024, and they also found a significant drop in physicians and the hospitals from about 71.5% to 40% in January of 2024. And I would submit that now, even more information is coming out about what went on during COVID. So I don't think that it ended there. I would submit that we might even find that to be lower. So this one, lucky for me, I put red arrows up since I don't have a pointer, but at the top, it is actually some good news. You know, this isn't all doom and gloom. You can see that overall, the view of medical doctors, according to this Pew Research Center poll, it was done in 2019, so this was right before COVID. Overall, people had a mostly positive view of medical doctors, right? 74% of people said they had a mostly positive view of a doctor. However, if you look at that second red arrow there, or the first red arrow actually, 15% of people, all or most of the time, felt that their doctor was transparent about conflicts of interest. And when I went through training, and even now when I do my CME, it's very typical to have conflicts of interest up. And in fact, that's why I had the titles under my name, because that it's not that I'm biased, but where I work now with Dr. Gold, I lean towards certain beliefs, right? And so it was very admirable that Dr. Lynn Flynn can get up here and say she does not have financial conflicts of interest. That should mean something to us these days. And then secondly, the lowest on there. Most people, 12%, felt that their doctor did not admit mistakes or take responsibility all or most of the time. It's pretty catastrophic, right? Okay, so when trust is lost, what happens? People delay care, they delay treatment, they doctor shop, and they have fragmented care, right? If they go and they have a bad experience with a doctor, they try and find another doctor that they can get a relationship with and trust. So the silent treatment, I bet many of you have experienced this because I experienced it during COVID in a manner that you couldn't ignore it. So patients sometimes feel they're being difficult or they're being argumentative if they just don't take every recommendation without questions or comments or even concerns. And I will tell you that many clinicians like myself also felt it, and it was triple-fold. So I was reported to the boards for speaking at a local health department. I was one of probably 5 or more clinicians, and I was the one clinician that this person apparently disagreed with so vehemently that I was reported to the boards. I had backlash from my colleagues. I had backlash from my professional organization. I had backlash from my medical group in general. So when people are silenced, that allows the status quo to continue, and it continues unchallenged. So that's why it's important that you all are here and that these doctors and clinicians are here. But it's not all doom and gloom, because there are ways to build the trust, and I would say to even restore the trust, but it starts with information and consent, and we will go through what informed consent means. Shared decision-making is a newer term, I would say, but it is becoming very important that patients take an active role in deciding making these healthcare choices. And then I would also submit that tone and discourse are very important. In some ways, I really wish I would have got to piggyback Dr. Angie's talk, because you're gonna notice many similar overtones in our talk. So informed consent, I'm going to read this definition because it's very important. Informed consent is a patient's voluntary authorization of a medical intervention after receiving sufficient information about the risks, benefits, and alternatives to make an educated decision. So disclosure, as we discussed, that's very important. They should disclose what a reasonable patient needs to make an informed decision. Obviously, they need to comprehend the information. It needs to be voluntary, without coercion, and I would also add without incentivization, because I know many of you remember COVID shots were rewarded with t-shirts on college campuses, donuts, free iPad drawings. I don't consider that coercion, but it's rewarding a behavior. And again, I would consider that an undue influence. Obviously, the patient should be competent to make that decision, and then the consent must be explicit authorization. Dr. Meryl Nass is amazing. I took this snapshot from her recent Substack article regarding informed consent. I disclosed that I am not a member of the AMA, but I put this slide up there to show you that they believe it is fundamental in ethics and law. And right in the middle of that paragraph, it says, successful communication in the patient-physician relationship fosters trust and supports shared decision-making. So here we will be moving from informed consent to shared decision-making. And what I want you to know about shared decision-making is it's not as well established in law, And it's used more as the mechanism to make sure that informed consent is actually credibly done. Okay, so shared decision-making is where they both participate. The clinician gives the risk, benefit, and alternatives. The patient shares their preferences, their values, and their beliefs, and they come together and they make the best decision for that patient. Oops. Okay, so this slide is basically objective number 2, and it highlights certain organizations and their stance on shared decision-making. The one in the middle will be Dr. Gold's favorite, and that I highlighted because it's the most unique of the shared decision-making. And if you think about an emergency room, if you go in and you're with 104 fever and you're septic, you maybe don't have the time or the relaxed, manner to go through do nothing and all alternatives because it's more fast-paced, there's higher stakes, there's more urgency to that. But even in emergency medicine, the trend is going to shared decision-making tools where they can show you quick pictorials or graphs and help you make that. The top one is the CDC and the Advisory Committee on Immunization Practices, the ACIP. And I want you to notice the little phrase there, uses shared decision-making for certain vaccines. The AAP promotes shared decision-making for decisions in pediatric care where trade-offs exist. And then the American College of Surgeons and the AMA and the AAFP all pretty much promote shared decision-making, and the surgeons especially in elective surgery. Okay, so with all that said, you would think that with the recent ACIP recommendation to move from a routine recommendation to a shared decision-making for infants 6 months to 23 months of age and healthy children, that would be applauded. But indeed, it recently was not. So Friday, September 19th, just recently, the ACIP did recommend moving away from that universal mandate or recommendation, and the AAP thus far has continued to recommend these injections. In the interest of disclosure, I did find this American Academy of Pediatrics corporate donors to Friends of Children's Fund, and I'm sure some of these names, probably should be disclosed when they are vigorously recommending things or if they are not going to move with recommendations. I think, again, these disclosures should be made available to the public. I'm going to pass over this in the interest of time, but I think that, I'll just pass on this. It's pretty. This just gives you a pictorial of what we talked about earlier, that the ACIP, CDC recommends shared decision-making for certain vaccines. You can see on the bottom the routine and universal vaccines that they consider more settled science. And so we apparently are unsettling the science by asking questions. So informed consent and shared decision-making pitfalls, too often it's seen as doctor knows best. The patients feel rushed. They feel like they're dismissed. They feel like their concerns are not even considered. Clinician priorities do not always equate to patient priorities. And I think the biggest way that I see this is our local health department, was very proud of their Shots in Arms campaign. And that was literally the slogan, Shots in Arms. So that was their priority, Shots in Arms. A new mom's priority is, what is that shot in the arm of my newborn meant to do? Is it safe or effective? Again, are the priorities the same? This one is going to become very evident why it's very important, because I have some real life examples here. And how does a patient know they have received sufficient information or appropriate disclosures if they are hearing that in a patient room and they're not medically trained? Just want you to think about that, and you'll understand why I want you to think about that when I give you the next example. And then, who determines when shared decision-making is or is not an option? Okay, so these 4 snippets that I'm going to play for you were taken out of an interaction with a pediatrician and a mom of a newborn. And the new grandpa walked into the room with his newborn granddaughter, and right after he walked in, the pediatrician walked into the room. And he could tell within the first couple of seconds that he wanted to record what was happening. And so I'm going to play these just back to back to back, and then we're going to go through them, and we're going to try and make some lemonade out of the lemons. I don't hear it.
It's not going to work in this setup. We'd have to play it from upstairs.
Oh, can you play them through then, please, for me?
Yes, stand by.
Thank you.
Vitamin K is an innocuous, it's a vitamin. There's no preservatives, there's no aluminum, there's no manufacturing, it's safe. So of all the things I would recommend doing, I recommend doing your vitamin K.
Okay, yeah, well, we can talk about it.
Yeah. Watch out. Okay. So I want you to think about it before you sign the refusal, because I have to have you sign the refusal.
Okay.
Okay.
Yeah.
Also, I've been doing this for 40 years.
Yeah.
Got gray hair.
Yeah.
And, I've seen babies die from every illness
Yes.
that we vaccinate from.
Yeah.
And so we don't let people come to the office who don't vaccinate. And there's no preservatives in the vaccines. They're single-use vials. There's no aluminum. It doesn't cause autism and blah, 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 blah,
Yeah.
blah, all the crap that's out there. And when I was a resident, way back when, we would see meningitis every night.
Yeah.
Every night. Strep pneumonia, meningitis. And if they survived, they were deaf or they're impaired.
Yeah.
And now we don't see H1 meningitis.
Yeah.
We don't see strep pneumonia, meningitis. We've been doing that since 1992.
Yeah.
So these vaccines are like life-saving.
Okay, so that was just some snippets. She did end this with, please write down your questions. I'll be back tomorrow morning. And I'm sure that you understood that they probably didn't feel that comfortable asking questions from that interaction. The only thing that I really want you to take away from this is the one little part that she says, the drops you have will not work, period. Do you remember when Dr. Farella was up here talking about the oral vitamin K? Is this appropriate discussion of risk, benefit, and alternatives? And this is how a patient walks away from the hospital, and this was not a very good impression of our medical system. So, getting back down, these are, again, pretty obvious with that example, but again, do you feel that the information in the disclosure was accurate? How would the typical patient know that oral vitamin K, it is available, it is an option, but it does have to be given, orally on a schedule. And so that was incorrect. Also, I went back and looked up because I didn't know where she did residency, and I didn't know how many years ago, but I was pretty sure she didn't see babies dying every single night of meningitis, and the only ones that survived were all deaf or impaired. And again, that is exaggerating, medical knowledge to people who wouldn't know that, because again, I thought it was exaggerated, but you can't just accuse that. So again, we need informed consent to be accurate and not over the top for patients. So PEARLS, and this is objective 3, for both the patient and the clinician, provide relevant, accurate information to the patient. Acknowledge your professional leaning. It's all right that she believed the shot was the best. She could have easily said, as a physician, I'm trained to recommend the injection because it's the most reliable protection, but I want you to understand all options and make the choice that fits your values. And then 3, tone. Tone and discourse. We've lost that. We've lost that decorum in the social elements of society, whether that's political. We've lost it amongst our colleagues as clinicians. There is no debate. You're called an anti-vaxxer. If you have questions, you're unsettling the science. You deserve to be reported to the boards. We will not have adequate health care in this country without taking back some civility in the tone and the discourse. Thank you all very much.